between 18 and 24. The reason that question was don't pick exercise is because that question had to do with osteoarthritis and not osteoporosis. Osteoarthritis we're going to talk about today, and then you'll understand why they don't do weight-bearing exercise. It's because osteoarthritis is arthritis of a joint that's been overused or has weakened over time. Osteoporosis, and I'm only saying this because I don't want you to get it wrong on NCLEX. Osteoporosis is brittle bones, is decreased bone density, but it is okay for these people to exercise and do isometric exercises and even do walking as long as it's in moderation. That's okay. That's recommended actually for people with osteoporosis. So I just wanted to clarify that. The other question had to do with osteoarthritis, which is a different disease. Right, so osteo means bones. Osteoporosis means weakened bones. It's a common chronic disease resulting in low bone density. We talked about the patient getting a DEXA scan. We talked about yesterday what osteopenia means. Basically, it's the beginning of osteoporosis. And then basically we get a number. We figure out your age and if you're female or male and what your bone density should be at that age in your life. And then it's compared to what the standard would be and then helps us determine, are you developing osteoporosis? What's your baseline? And then as you age, is it getting worse? Bone mineral density peaks, we talked about this, between the age of 18 and 30, and then every year after that it decreases by about 1% per year. Here's our risk factors we talked about yesterday. Here's a picture of somebody with osteoporosis. That's not what I was trying to do. Get back to the PowerPoint. So here's our risk factors: getting older, being small and thin, having a family history, certain medications that the patient might be taking, white or Asian, Caucasian or Asian people are more likely to develop osteoporosis. So it is a disease more of Caucasian people, females, postmenopausal, lack of estrogen. Again, that small, thin body build to start with puts you at risk for osteoporosis. And as you age, that bone density becomes weaker and weaker. Here's our CDEFs of osteoporosis. Have the patient take calcium, vitamin D. They can do weight-bearing exercise, again, in moderation to what they can tolerate. They don't keep doing it if they're in pain. But this is a way to help prevent osteoporosis, because what that exercise does strengthens the muscles and the ligaments and the tendons around the bones and helps keep the bones stronger. And then, of course, prevention of falls. That's a big deal for these patients, because if they fall, they have weak bones and they're going to have a lot more complications. So CDEF, that's a way to remember what's our treatment for osteoporosis and what can we do to try to prevent it from getting any worse. And if the patient's diagnosed with it, what would we do to treat them? Here's some of the meds that we talked about. Actonel is the one that I've given. Fosamax is another med that you'll be giving, and you'll hear of that and you'll see it on patients' MARs, and it's for bone density and weakened bones and for osteoporosis. Usually Fosamax is a once a week kind of drug. It's a pill and they take it once a week in order to try to help strengthen their bones. Actonel, I think that one is a once a month, and I think Beniva is a once a month. Yeah, that's what it says. Beniva, once a month medication. Again, be careful when the patient's taking these medications. They are very irritating to the GI tract, so many times they have to take them with food or at certain times of the day, and there's certain requirements with these meds, and just we need to be aware of it when we're administering these meds to the patients. So here's our risk factors. Here's why it happens. Most common in women in 50s to 60s. Steroids, we talked about high use of caffeine. Drinking a lot of coffee is going to put you at high risk for osteoporosis. Your diet low in calcium, your patient that's lactose intolerant, your patient that's obese, your patient that's a smoker, your patient that has a sedentary lifestyle. These are all the things that contribute to somebody having osteoporosis. Here's our test that we're going to do in order to determine that they have it. CBC might be done. What about a SED rate? You think that might be high? Could be. There could be some inflammation around their joints. Phosphorus levels usually going to be low. We talked about what normal phosphorus level is yesterday. Calcium is going to be low. We got to go back and remember what's normal calcium, 9 to 10.5. So that number is going to be low for this patient with osteoporosis. They could have a low BUN and creatinine. Could be because maybe it's their kidneys that aren't working, that aren't making calcitrol. They're not using calcium for their bones. So now we look at the whole picture of the patient and what could possibly be happening and making their bones weaker. And then what can we do about that? How can we supplement? How can we get them medications to try and make their bones stronger? How can we recommend an exercise program for these patients? What can we do in order to try to prevent this from getting worse as the patient ages? And here's some of the meds that we might use. Calcium supplements, vitamin D, there's that alendronate, that's Fosamax. Weight-bearing exercises are okay for these patients. Estrogen therapy, if they're postmenopausal and they need hormone replacement therapy, that's okay. Pick that. That's a good option for you. Stop. Here, somebody is not needed. Excess caffeine consumption causes increase of calcium in the urine. That's what happens. So not a lot of coffee, not a lot of sodas with caffeine, not a lot of chocolate products for this patient. Here's the foods and vitamin D, fish, egg yolks, fortified milk, and cereal. Calcium, here they are, our dairy products, green vegetables, beans, we talked about that yesterday, fortified orange juice. Recommend exercise for these people. Weight-bearing exercise is okay. And then if there's a secondary reason, if there's a different reason why the patient is developing osteoporosis, try to figure out what that reason is, and is there anything that we can do to correct that? Sometimes there is, sometimes there isn't. The patient's taking seizure meds, puts them at high risk for osteoporosis. The patient's taking steroids, higher risk for osteoporosis. So you have to remember there's certain categories of meds that might put this patient at risk and figure out, okay, what are the risks versus the benefits? They might need to stay on this med for seizure reasons, but we got to now supplement their diet and give them other medications to prevent their bones from becoming weaker. So here's our primary reasons. Usually women, a little bit younger. Look how it affects the men, usually not until about 75 or later. Asian people are in a higher category, Caucasian people in a higher category, people that are postmenopausal, people that have decreased protein in their diet, sedentary lifestyle, people that smoke, people that have chronic alcohol use, all in the high risk category for osteoporosis. Here's some of our meds. This is a secondary reason, meaning they're taking the med for something else, but now that medication has created this effect. Steroids, phenytoin, that's Dilantin, that's for seizures. Carbamazepine is Tegretol, that's for seizures. This is in the category, it doesn't say it here, but anti-seizure medications lead people to osteoporosis. Loop diuretics are in the category. So they not only lower our potassium, but they also put us at a little bit higher risk for osteoporosis. Prolonged immobilization, who would that be? That might be your patient with a spinal cord injury. It might be your patient that is very sedentary and does not get up. That might be your patient that has some kind of physical trauma that they're on bed rest for weeks and months of their life, and now they've developed osteoporosis. Because what that exercise does, us getting up and moving around, stimulates blood flow to our bones and to our tissues and to our ligaments and helps keep us stronger and healthier. It makes sense. If we're up and exercising, we're going to stay healthier longer. So here's our health promotion. This is going to be your question on NCLEX. What are we going to do? What's our select all apply for this patient? Reinforce the client to take in calcium and vitamin D, especially before the age 35. So start early, take your multivitamin, keep calcium in your diet. If you're lactose intolerant, find other ways to get calcium. People that are anorexic and bulimic early on end up with physical body changes later on in life because of their poor diet, even in their adolescent years. Foods rich in vitamin D are here. We talked about limiting carbonated beverages and caffeine products to try to decrease that out of your diet because it causes calcium loss. Encourage the client to get vitamin D out in the sun, expose the skin to sun 5 to 30 minutes twice a week. It's talking about hormone replacement therapy. And here's our recommendation for exercise. Weight-bearing exercise is walking 30 minutes at least 3 times per week. So again, it's something that is helpful early on in life to keep our bones more dense and stronger as we age. And once a person, starts developing osteoporosis, it doesn't mean to say no more exercise. Again, they're going to have an exercise plan that helps keep their muscles and ligaments and tendons strong and help support their bones. So here's our expected findings, things that we would expect to see if a person is developing osteoporosis. It is different than osteoarthritis, so we've got to be able to compare the two things. Expected findings for this person: reduced height. So they have that kyphosis curve is what it's called. The top part of their back ends up kind of curved over. They, again, might have back pain with activity. Their spine is weakening because the bones in their spine are weakening as they age. They may get pain from a compression fracture. Again, they may have a history of fractures now that they've never had before, meaning a wrist fracture. Easily fractured bones is what happens with these patients. That's why they're on fall precautions to begin with, because their bones are not as strong as they were when they were 18 or 25 or 28 or whatever age. And then there's that kyphosis. You might see that in the select all that apply. That's that person that's kind of slouched over, and the top part of their spine, the thoracic spine, ends up kind of curved rather than straight up and down. And that's a typical expected finding when somebody has osteoporosis. So here's our patient-centered care. Read through this, because this is what you're going to pick as your select all that apply for these patients. What are we going to do? What are we going to encourage them to do? When you get questions on NCLEX, it's going to be education kind of questions. What would you tell the patient to do if blah, blah, blah? What would you recommend the patient take in their diet? What would you recommend as far as education for this patient that was recently diagnosed with osteoporosis? And it's going to be all of these things right here. These medications, their diet change, limiting their caffeine, don't drink carbonated beverages, all of the things that are listed here are going to be part of your educational plan. Is every patient going to do every one of these? No, but it's up to us to give them the education so that they know how to prevent this osteoporosis from getting worse. So we answered a couple questions yesterday about it. Now we're going to talk about arthritis a little bit, and you can see right here on the first slide, it's talking about osteoarthritis. So that's different than osteoporosis. Osteoporosis is low bone density. Osteoarthritis is just that, arthritis or inflammation in one or more joints. And osteoarthritis and rheumatoid arthritis and gouty arthritis are all arthritis types, but they are all a different type of arthritis, and they get treated in a different way. So we'll talk about that over the next few slides here. So what is arthritis anyway? It's inflammation. So if you start there and you know the patient has inflammation, what do you think is going to be high when you get their blood? Probably their white blood cell count could be high with inflammation. Their SED rate will be high. That's the erythrocyte SED rate. It's going to be above 20. Another lab for inflammation is your C-reactive protein, CRP. That's going to be elevated. So if you see something in a story, C-reactive protein, and it's an elevated number or it's elevated on the labs, it's because of inflammation. So the patient with arthritis has pain, has swelling, has stiffness, limited movement in a joint. Most of the time, osteoarthritis affects your knee and your hip joints. Again, it's more the joints that are movable and that we use all the time. That's why that question relates to the patient with osteoarthritis. If they have arthritis in the knee joint and they continue to exercise, it's going to make the arthritis worse. How we recognize osteoarthritis is it's called wear and tear. And you can write that down. That's what it's called, the wear and tear type of arthritis, meaning you've been using it and it over time has worn out. So that's your knee joints, that's your hip joints, that's your patients are going to get a total knee replacement or a hip replacement or a hemiarthroplasty. What's that mean? Half of my knee was replaced, not the entire knee. And it's usually because they've developed osteoarthritis in those joints. So it's usually from wear and tear. It's usually from the patient being obese. It's usually from repeated use of something. So again, depending on what you do for your job, what you do for a living, how well you've taken care of yourself. If you've been obese for 30 years of your life, you're going to be more likely to develop osteoarthritis because you're putting more weight on that joint every time you walk and move and use that joint. Rheumatoid arthritis is different. Rheumatoid arthritis is an autoimmune disease, And it doesn't just affect the joints that we use more, it affects joints in our entire body. So that's how we can compare the two. Gouty arthritis is exactly what we talked about last week when we talked about renal, is the patient has developed gout, the patient has uric acid crystals that have built up, and those uric acid crystals create arthritis in certain joints in our body. So there's 3 different types of arthritis, and you got to recognize the difference between those 3. So osteo is wear and tear. That's from use, and it's usually joints that we use more than others, and it usually develops over time, and it's usually inflammation and pain with activity, pain with movement. Rheumatoid arthritis is an autoimmune disease, and what that means is your body attacks itself. That's what autoimmune is. Rheumatoid arthritis usually has an earlier onset, meaning that the patient that has rheumatoid arthritis, usually in the teenage years or early 20s. Osteoarthritis is usually your patient in the 50s, 60s that has used this joint for the last 30 years or 40 years, and now is starting to develop arthritis in their knee and hip joints. Gouty arthritis is typically your patient that has renal disorders, or your patient that their kidneys aren't working, because it all kind of goes hand in hand with those uric acid and that urea building up in their system. So there's 3 different types of arthritis, and we got to understand how our signs and symptoms are going to be a little bit different, why it happens, and then again, the treatment's going to be different depending on the type of arthritis that it is. So arthritis itself, what's it mean? Inflammation of one or more joints results in pain that should say swelling, stiffness, and limited movement. And you can see if this knee joint is arthritic, this is somebody's knee, and it's red and inflamed, it's going to be painful when they move it. It's going to be more painful when they exercise. These are the patients that over time can't tolerate the pain, have decreased range of motion, can't get up and walk like they used to without having pain. Those are the ones that end up with the knee joint replacements, and then obviously they hopefully will have a better quality of life after that knee joint is replaced. So osteoarthritis, DJD, is known as degenerative joint disease, meaning over time the joint degenerates or starts to deteriorate. Occurs most often in older people. Younger people, yeah, they can get osteoarthritis. Maybe they injured their knee or their hip, most of the time a knee or maybe an elbow while they were playing sports, and it really never fully recovered. That sometimes happens. But most of the time, the people with osteoarthritis are going to be middle-aged to later age, older adult, because it's a degenerative disease. As the patient ages, the joints get worse. It typically happens gradually over time. Some of the risk factors, here they are, same things we just talked about: being overweight, getting older, maybe you injured your knee and a skiing accident when you were 18, and now you're 45 or 50 and this joint is not holding up anymore. It could have been that you had some kind of injury years ago that has now created likelihood for it to be arthritic later on in your life. Maybe it's a joint that didn't properly form from birth, and that's that baby with that Bryant's traction because their hip didn't generally form the right way. And now later on in life, they develop arthritis in that hip. Again, stresses on joints from certain jobs and playing sports. So think about jobs that, if you're a construction worker, if you're up and down a ladder every single day because you're a painter, you're going to be more likely to develop arthritis because you're using those joints over and over again. And that's why it's called wear and tear. That means that they use the joint so much that it has worn out, and now basically arthritis has happened. So there's your football players. Who knows? They play football 10, 15, 20 years out of their life. They developed osteoarthritis because of overuse of those knee joints or whatever joints. And I keep saying knee because that's a lot of times where this symptom first shows up. It's the most common type of arthritis. Again, here's some numbers. Don't memorize the numbers, but 27 million Americans have osteoarthritis. Who knows what that number is right now? There are 3 different types of arthritis, but this is the most common one that you're going to see. It's referred to as wear and tear. If you see it called DJD, it means the same exact thing, degenerative joint disease. Primary, what happens? Progressive damage, it's gradual, it's over time, it's wear and tear of the joint, and the patient has now developed arthritis. And look, 70% of people over the age of 70 have some evidence of osteoarthritis. It's just some people have it worse than others. So here's our symptoms. Patient has joint pain. Patient has pain, and here's some of the key things about it that makes this different than rheumatoid arthritis. The patient with this type of arthritis has pain that with activity that improves when they sit down, improves when they lay down, gets better if they stop using that joint. So here's your patient that has knee pain. They have osteoarthritis in their knees, and they get up, they walk around, they notice the pain's getting worse. But when they stop and they stop using those joints, the pain gets better. Localized inflammatory response. What does that mean? That just means in those knee joints or that hip joint that they have osteoarthritis, or even in that elbow that they have osteoarthritis, that's where the reddening erythema, that's where the warmth, that's where the tenderness is. It's not throughout their entire body. It's in that specific joint that they have arthritis. They have limited movement. They have crepitus. That's that like crackling kind of popping sound that could be in their knee or their hip or their elbow. And then they have some called Heberden's nodes closest to the fingers and toes. So you can get osteoarthritis in your hands because you've overused your hands for years and years, depending on the type of job that you do. Maybe you're a typer or something like that. And I'll show you a picture of what these nodules look like. But this is the patient that you see those arthritic hands that are kind of curled up. They look abnormal. They have big knuckles, it looks like. Big round nodes on their knuckle joints. This is the patient with osteoarthritis. And again, maybe they're developing fluid around their knee. Maybe they have atrophy of their muscles because they don't use them. And I think there's some pictures in here of these, thought there was, or these nodes. But I'm sure that you know what I'm talking about because you're taking care of patients that have these. Sometimes their fingers are kind of curled up a little bit. Their knuckles are large and round. They have pain when they move their hands. They have trouble feeding themselves if it gets bad enough, and they have to use a different type of spoon in order to be able to use it and feed themselves because they don't have the same range of motion, and dexterity is the word for their hands that they once did because arthritis has set in. And usually, again, it's somebody that's 65, 75, a little bit older by the time all of these chronic changes happen. So what's the treatment focus on? Controlling pain, preserving the function of the joints, and slowing down the disease. So here's our medications. These are what you're going to pick. I know when you guys just did your ATI grid, we talked about DMARD medications. These people take those DMARDs. They're called disease-modifying anti-rheumatic drugs. What does that mean? They're the medications that help stop the progression of these diseases. They might take NSAIDs. That's okay, but remember now, what's the side effects of NSAIDs? Are their kidneys working that they can take NSAIDs? Do they have a risk for bleeding? Well, maybe they can't take the NSAIDs if they already have a history of bleeding or some kind of bleeding disorder in the past. So you have to think about what meds will work, what's going to control their pain. And remember, that's our main option, controlling pain, preserving the function, and keeping it from getting worse. And then if we can't control the pain and it keeps getting worse, we're going to do surgery and probably replace one of those joints that need to be replaced because it's so arthritic, it can't get better. So here's our medications. NSAIDs, they work for these patients. Why? They decrease inflammation and they decrease pain. So while Tylenol might be okay, NSAIDs are better because they have an anti-inflammatory part to them, where Tylenol doesn't. Tylenol is more for fever or for pain. So here's your patient taking NSAIDs. They might take Motrin, ibuprofen, Advil, Aleve. They could take steroids. They decrease inflammation. That's what steroids do. So they might be put on medication ending in SONE, like prednisone, methylprednisone, some kind of medication like that, where they now decrease inflammation and help control the pain that the patient has. They can exercise, but again, remember, the exercise is only to the point of pain for these patients. So if they're mild osteoarthritis, yes, the doctor will say, yes, continue to keep your joints moving, but exercise to the point of pain. So if you start to have pain, you need to stop, because what that means is you're wearing down that joint a little bit more. Of course, it's going to be weight control, because the less weight you're putting on your joints, the better off you're going to be. And they, again, alternate between using ice and heat for these patients. Like, what are we doing that for these patients? To control pain. They need physical therapy, and then if all these things don't work, they end up with a joint replacement. So by the time they get to that joint replacement that we talked about earlier on in the week, they've done all of these things. They've tried NSAIDs, they've tried steroids, they've tried lotions, they might have used Bengay, to treat pain. They might have been on exercise program for a few weeks or a few months to try to help mobilize those joints. But again, remember, exercise, if it looks like in the story that patient's exercising 7 days a week, that's not the osteoarthritis patient, because that's only going to make it worse. It's a limited exercise program for these patients to the point that they can tolerate it and not have pain. If they're starting to have pain, that means that that joint is wearing down a little bit more, and that's not what we want to happen. We want to try to slow it down. So here's our goals: control the disease, relieve the pain, help the patient be functional and get back to their ADLs, and maximize their quality of life. And again, these meds can do that. DMARD medications can do that. There's another DMARD medication, I don't know if you guys saw it come up in ATI, it's called methotrexate. That is a DMARD medication, and all that means is disease modifying. What does that even mean? It just means that it slows down the progression of the disease. So you might see an osteoarthritis patient put on methotrexate and an NSAID. Anything we can do now to control their pain, help maximize their quality of life, help them stay functional, help them maintain their quality of life as long as they can and be as good as they can, are going to be meds that we do before we opt for surgery. So we're going to do all the other things here first before we just say, okay, you need your joint replaced. What we're trying to do is slow the disease progression by doing all of these other things first. Rheumatoid arthritis, what's the difference? Rheumatoid arthritis is autoimmune. All that really means is you have destruction of bone and cartilage. Inflammation is happening, but it's your body creating this inflammation. The things that are different about rheumatoid arthritis, it's not wear and tear. It doesn't mean that you overuse the joint. It's not one specific joint in your body. Many times it affects their entire body. And that's important. That's important because we need to recognize that a person with rheumatoid arthritis, yeah, they might have knee pain, but they also have hand pain. They also have inflammation in their lungs. They could have inflammation around their heart. They can have inflammation anywhere in their body. So their pain is a little bit different. They hurt all over a lot of times. There's joint deformities that happen anywhere in their body. It's not because they had wear and tear of a certain joint. It's because of the autoimmune disease, and their body is kind of attacking itself. This is basically a physical picture of what happens. Yeah, they lose bone density like osteoporosis, but it's a different disease. They have joint deformities. They have increased soft tissue swelling, and this is their knee. Yeah, it can affect their knee, but it also can affect many other places in their body. So look at this patient picture with rheumatoid arthritis. They are overall inflamed. Lots of different joints are inflamed. So they feel tired everywhere. They have weight loss. They're usually skinnier patients. They're not the obese patients. They end up looking, sometimes if they get really sick, they look unhealthy. They don't have good nutrition. They end up losing weight, and it affects their shoulders, their elbows, their wrists, their knees, their ankles, like kind of everywhere. They end up with multi-system involvement. So that's way different than osteoarthritis. It's not just one or two knees that are affected. This is everywhere. Usually affects joints symmetrically. What does that mean? It means same joint on both sides. So that means a patient, when they have symptoms, will tell you, I have pain in both of my wrists. So it's not a wear and tear. I use my right wrist more than my left. It's not like that. It's pain on both sides. Both of my knees hurt. Both of my shoulders hurt when I move my shoulders. They can get inflammation around their heart, so they can develop symptoms similar to like pericarditis and endocarditis because of the rheumatoid arthritis affecting their heart. So again, read through this. Rheumatoid arthritis usually affects joints symmetrically, meaning on both sides of the body. It may initially begin in just a couple of joints, but frequently attacks the wrist, the hands, the elbows, the shoulders, the knees, and the ankles. And again, your patient in this picture will say, hey, both of my knees have been hurting for the last 6 months. They are usually younger patients. It's usually an autoimmune disease that kicks in earlier on in life, And so they haven't worn and torn any joints, they have just developed this disease. And these patients can get very debilitated with rheumatoid arthritis. Many times they're on some of the same similar medications, NSAIDs, steroids chronically. So now they have to worry about all the side effects of steroids, but they have to treat their pain. They might be taking methotrexate. They take some different types of their medications they take once a month as injections in order to try to minimize the symptoms of rheumatoid arthritis. So here's their symptoms and how it is a little bit different than osteoarthritis. Here's the diagnostic test. How do we figure out that you have rheumatoid arthritis? These are blood studies. This is important for you to recognize. There's a blood study called a rheumatoid factor, RF. When a doctor suspects a patient has rheumatoid arthritis, they draw this lab from the patient, and the rheumatoid factor is elevated. It's greater than 80%. Of the people have this. And how do we know what it says? It'll be elevated rheumatoid factor. You don't even need to know a number for that. You just need to know that it's positive when people have rheumatoid arthritis. It's not like that when they have osteoarthritis. Why? This is just something in our blood that is released by our body when we have this autoimmune process happening. So they'll have an elevated rheumatoid factor. They have an elevated SED rate, just like osteoarthritis does. And there's that C-reactive protein, and that's elevated too with inflammation. How do we know for sure? They end up many times drawing some fluid from the patient's joints, and they can do a fluid analysis. Remember, go look at this. X-rays won't diagnose it. They're only going to show you changes to the bone. That's what an X-ray does. So your patients that are going to be diagnosed with rheumatoid arthritis, it's going to be they have a positive rheumatoid factor, and they end up drawing some fluid from their joints, and we're able to tell that there's rheumatoid arthritic changes happening in these joints. These patients get treated with medication. Can they get joint replacements over time? Yes, they could if this rheumatoid disease is really affecting their knees to the point of pain. Remember, we're doing all this treatment just to get the patient for a good quality of life and back to the best level of functioning that they can. Don't study this. You don't need to it's not an A&P class. This is not what's going to be on the exam, but you need to recognize that this disease is different than osteoarthritis. This is what happens and why the joints wear out. And you can see how that the granulation tissue grows into the joints, and the joints have less mobility and pain when the patient moves. This patient typically has different symptoms though. Again, they're usually same joint affected on both sides of the bodies. The patient usually has morning stiffness. That's a little bit different. The patient with osteoarthritis has more pain with movement. The rheumatoid arthritis patient actually is the opposite. When they get up and move around, they start feeling a little bit better. They actually feel worse after they lay still. So that makes it a little bit different for this patient. This is just talking about the etiology, the cause, why it happens. All I want you to do is read through it, and this is what happens. Your body attacks itself. It develops antibodies and basically creates this inflammation on its own. It's not because you use the joint too much. Here's some of their symptoms because it affects the entire body. So this is important. This is different than osteoarthritis. It's not just one or two joints, it's everywhere. So the patient's eyes can be affected. They might be sensitive to light. They might have eye dryness and pain. Their mouth can be affected, and their mouth might be dry. They might get gum irritation. Their skin can be infected. They might get small lumps under the skin over bony areas, like maybe their knuckles, their wrist, anywhere where there's a bone, they can develop these lumps. They can get inflammation in their lungs, and they can be short of breath. They can get inflammation around their heart, and they can have chest pain. They can become anemic because the rheumatoid arthritis is affecting their blood and their circulation. So lots of different things can happen because they have high inflammation in everywhere throughout the body. So it's different than osteoarthritis. Here's the goal. Stop the attack. Stop the disease from getting worse. Medications. Again, tight control of the meds. Keep the rheumatoid arthritis under control so the patient doesn't develop symptoms everywhere in their body. Again, a lot of this is medication driven. They're on 2, 3, 4 different types of meds, and then they have side effects from the meds that they're taking. So here's another picture, same picture we looked at. Usually the joints are affected on both sides of the body. This is your rheumatoid hand. Right? This is your patient again. I've seen many patients with arthritic type hands. Sometimes it's osteo, sometimes it's rheumatoid arthritis. You just gotta, figure out what the patient's been diagnosed with. But again, changes in their hand can look like this. This is a normal hand with normal joints. This is a patient with rheumatoid arthritis, and the joints in their hands are a lot of times deformed, abnormal. Again, they don't have good range of motion of their hand. They can't hold on to things. They might need a different type of cup. You might get OT involved with these patients because they can't hold onto a cup in order to drink because their hands are deformed and don't have the normal ability that we usually have. So this is just showing you another picture of normal. This is an osteoarthritis joint, the bones rub together. This patient with rheumatoid arthritis, what's happening is around the joint, there's a lot of fluid that builds up. That's called synovial fluid, and it's called synovitis. All that really means is the synovial fluid around here is inflamed. So you can see the different picture. This is wear and tear where these joints are rubbing up against each other. We've used them so much. The bones have kind of fused together and they have inflammation. And when I exercise or use these joints, they hurt. This patient hurts no matter what. Even if they're not up and exercising, they have a lot of inflammation and redness in the joint, and they have pain even when they wake up in the morning. So how do we diagnose it? Well, one of the key things is that rheumatoid factor. To make it different than osteoarthritis, they have a high SED rate, they have a high CRP, they have a high rheumatoid factor. Here's our medication: NSAIDs, steroids, DMARDs, immunosuppressant drugs like methotrexate, cytorex is another one. These are meds that you should have seen in your ATI grid, and that should start clicking in that I've seen those meds written, and these are the patients that would be taking those meds. But they, again, have a lot of side effects, so you have to make sure the patient can tolerate them. Here's our steroids, but now we got to go back to what's our side effects of steroids. If the patient's diabetic, now they got to take steroids. Well, imagine now what's happening with their blood sugar. We got to worry about their blood sugar being up even more than it normally would be. There's a lot of different side effects of steroids. So people don't tolerate them. So the doctor tries to get the patient on as low a dose of a steroid as they possibly can in order to control the pain that the patient has so that they have less side effects from those meds. Here's our DMARD medications, and there they are: methotrexate, hydroxychloroquine. Guess what? We've all heard about that since COVID came out. That's a DMARD medication. It's been around forever. It's worked forever for these people with arthritis. It works to treat people with malaria. The other name for hydroxychloroquine is Plaquenil, but this is a med that has been around for years and years and years. It's a DMARD medication. It's a safe medication and not a lot of side effects from that one. Methotrexate has more side effects from it, so people don't always tolerate that one. But these are two of the meds that you might see this patient put on in order to try to control the rheumatoid arthritic pain that they have from this disease. Again, it's a disease. It's an autoimmune disease that attacks your body. And it develops, again, I keep saying it, earlier on in life usually. Okay, here's some biologic medications, and they're just a category of meds. Again, here's some names. You're not going to remember all these names. You just need to recognize that if this patient with rheumatoid arthritis, I'm going to give them NSAIDs, I'm going to give them steroids. Some of the DMARD medications I remember writing down on my notes from ATI, they might be taking these medications, and then there's another category called biologics. And what do? They block the inflammatory response of the body. So here's a good comparison for the two types of arthritis that most of the time are the most common that you're going to see. Osteoarthritis is definitely the most common. It's wear and tear. They have pain with activity. The pain gets better when they stop using the joint because it's overuse of the joint that created it to start with. They have swelling, redness, and warmth, but that swelling, redness, and warmth is usually maybe in one knee, not the other. Could be in both, but again, it could just be one side of the body. It could just be two knee joints, but not affecting the hip. This patient's usually overweight. This patient has those nodules, nodes in their hand and sometimes their wrist. This doesn't affect other body systems, and we can see arthritic changes in your bones with an X-ray. This patient with rheumatoid arthritis, it's different. It's inflammation in the synovial membrane. That's the fluid that's around all the joints in our body. It's an inflammatory response. It's autoimmune. Your body is attacking itself. This patient has pain at rest. They don't even have to do anything. Or the one key thing about rheumatoid arthritis patients, they're worse when they first wake up in the morning because they've been stiff. They have morning stiffness. This patient gets stiff and pain as the day goes on because they're using the joints more. So compare the two things, and it's important you compare these two because your symptoms are going to be a little bit different for your patient, and your story on NCLEX is going to be a little bit different. This patient affects all the joints. They're usually underweight. They have deformities in their hands. This patient can still have deformities in their hands with osteoarthritis, but usually this is the hands and the overall body symptoms are usually your rheumatoid arthritis patient. Lungs, heart, skin. And again, there's that positive rheumatoid factor. The x-ray doesn't always tell us everything with rheumatoid arthritis. Sometimes it does, but many times the x-ray is negative for that patient. We need to do a biopsy or draw some fluid from that synovial joint in order to determine there's excess fluid there and there's positive rheumatoid factor. And it's a different way of diagnosing that patient. Treatment kind of is the same, but you want to know what the patient is. With rheumatoid arthritis, you have to be thinking all body systems can be affected, so that patient can get much sicker quicker because their whole entire body could get inflamed. This osteoarthritis is usually a patient that's more middle-aged, that has used one or two joints more and worn out those joints, and now we have to talk about a joint replacement. So this person, rheumatoid arthritis, is a sicker person because the whole body is affected. Here's the Heberden nodes and Bouchard's nodes that we were talking about. That's the patient with osteoarthritis. And this is just showing you a picture of that. This patient over here with the curved fingers like this, that's the rheumatoid arthritis patient. So go back and compare the note. I've seen a few ATI questions come up about that as well. And here's a good picture of it so you can compare which type of disease process is probably going on. This is the rheumatoid arthritis patient. I always remember them. They're the ones that have like curved kind of fingers. They need OT, they need PT, they need assistive devices, they need different things for us to supply them, for them to even be able to feed themselves sometimes. Again, rheumatoid arthritis, here's the key things about it. It's autoimmune. The body attacks itself. Classic signs and symptoms: morning stiffness, pain, disability. What about the pain? The pain for this person, go back to this, is at rest or after they haven't been moving around. The pain for this osteo person is usually after they've been moving around and using the joint, and they get worse later on in the day. They're the ones that say, I've been walking, I've been at work, and my knee, I just can't walk anymore. And my knee is hurting so bad. This person with rheumatoid arthritis, they wake up stiff. They wake up with more pain because they haven't been moving the joint. So their symptoms appear differently, and they are different. And patients will complain of different things to you. So here's classic signs and symptoms: morning stiffness. This is usually women, more female patients with rheumatoid arthritis around in their 20s. So it's sad, you know, that they're that young and they can get sick pretty quickly. One thing about rheumatoid arthritis, because it's autoimmune, stress makes it worse. Once your body's under stress, whether it's physical, emotional, psychological, whatever it is, they a lot of times have a flare-up or an attack from this rheumatoid arthritis, and their pain gets worse. One thing about it, it's chronic and it's progressive. So we can't really stop it. We can't really fully make it go away. What we can do is treat it and hopefully help it from becoming worse and worse as the patient ages. So that's important to remember. Once you have osteoarthritis and it's just your knees that are affected and you replace your knees, you're going to be okay. You're fine. Your osteoarthritis is taken care of. The medications you took for a while didn't work. We replaced your knee joints. Okay, now your quality of life is good. This patient with rheumatoid arthritis, it's chronic, it's progressive, it gets worse and worse as they age. So what we try to do is slow down the progression as quickly as we can. Get you on those meds, get you diagnosed as early as we can so your disease doesn't get worse. So here's this patient, again, morning stiffness. That's a key thing that I always remember that may be a little bit different than osteoarthritis. Because it affects the whole body, the eyes are affected, the mouth can be affected, the lungs can be affected, the heart can be affected, the hands can be affected, both shoulder joints, both elbow joints. Hopefully you're getting a picture that this is a whole body system disease, way different than osteoarthritis. Here's our nursing care and intervention. A lot of the meds are the same, right? It doesn't change. They might do surgery. They might get a joint replacement if one or two of their joints are really affected bad and they have a lot of pain. Synovectomy means that we might have to remove some fluid from around one of those joints, and maybe that's enough to take care of the pain that you have. This person feels tired a lot, so we allow them rest periods. That's okay, because one of the symptoms of rheumatoid arthritis is fatigue. Do we encourage physical activity for them? Yes, we do. It's different than osteoarthritis. Why do we want these people to get up? Once they get stiff, their pain gets worse. So we want them to get up and move around. And usually the rheumatoid arthritis patient will tell you they feel worse in the morning than they do later on in the day. Once they get up and move around and start using their joints, they feel a little bit better. Here's our goals of care. They don't really change. It's the same as the goals for osteoarthritis. We talked about some of these medications. And just having this increases your risk for all these other heart and lung problems because it affects your entire body. It increases your risk for osteoporosis because your inflammation around your joints can make your bones weak. So these are some of the long-term complications that can happen from rheumatoid arthritis as it gets worse and worse. Okay, any questions about those two? Before we move into gouty arthritis. Then we'll take a break. Any questions about those two?
No.
Okay, what's gouty arthritis? It's a third type of arthritis. What are some of the things that we tell these people not to eat? Foods that have purine in them. Gouty arthritis can affect certain joints in the body. It's not autoimmune, so it's not the same as rheumatoid arthritis. It's not wear and tear, so that makes it a little different than osteoarthritis. People develop gouty arthritis because of their kidneys not working. So put them all in this category of high risk for renal calculi, kidney stones, high risk for renal disease or chronic renal CKD. The patient many times will develop gout right along with it because the urea that normally your kidneys get rid of build up. The uric acid builds up, and the patient ends up with an attack of what we call gout. And it's gouty arthritis, it means the same exact thing. What does it usually affect? The very first joint that it affects, I don't even know why, is the great toe, the big toe on your foot. It could be both feet, could just be one toe. And again, usually lower extremity, ankle, big toe, severe pain. What do we know about the meds for gout? Colchicine is the med that we use right now. You take one pill or two pills, and then in an hour you take two more. So it's a medicine that works right now. It's a strong NSAID medication, a strong anti-inflammatory medication. The important part with gout that we have to remember is the foods high in purine to tell the patient not to have them in their diet, because a lot of times that's the trigger that causes the gout attack. So here's your patient with gout. Here's our foods, things to avoid. We talked about this with renal, but we're going to go back over it again. Anchovies, mushrooms, asparagus, peas, breads, gravies, broth, chicken broth, alcohol, shellfish, seafood, beer, any of those things are what we tell the patient that has a history of gout or likely to develop gout not to eat in their diet. And sometimes if they avoid these things, they don't have gout attacks. I've had patients over and over again come in and say, okay, I had shrimp and beer on Saturday night, and now here I am in the emergency room with severe pain in my big toe. My gout's flared up, and you ask them what they ate, and many times it's a trigger from what they had to eat 24 hours prior to that. Gout commonly strikes between the age of 30 and 50, usually more in men, and most of the patients I've seen are taken care of with gout are men. Yeah, it can be postmenopausal women, but usually it's men. Many times it's your diabetic patient. Many times you ask them about their renal history and there's some kind of renal disease, or their kidneys aren't working quite properly and they can't get rid of the waste products and they build up in the crystals. And that's what gout is. That's what gouty arthritis is. So how do we manage it? Colchicine is going to be your answer for right now. Allopurinol, the other name for allopurinol is Xyloprim. That's your medication that the patient takes every day to try to prevent the urea from building up. Other meds that you might see a patient put on, Indocin, it's called indomethacin, it's an NSAID. They might get steroids if the gout attack is severe enough that they need some steroids right now. But usually the two meds that you're going to see on NCLEX are going to be colchicine for acute attack, allopurinol to prevent the attack. We want them to drink more fluids, and I'm not talking about beer or alcohol. Drink water, drink regular fluids to try to get rid of the urea in your body. We want to monitor their intake. We're going to keep them on bed rest for when that acute attack is happening, because these patients with this pain, it's like 10 out of 10 pain. It doesn't seem like it would be, but it is. And sometimes they can't even stand up on their foot. Usually the classic symptoms, pain in that big toe, this joint right here gets red and inflamed. And you give them the colchicine, and maybe 6, 8, 10 hours later, the pain starts to get a little bit better. Common joints that are affected are usually this great big toe, the ankle. It can affect the knees. Very rarely have I ever seen elbows or wrists. Usually it's the foot or the ankle that's affected, but it can affect other joints. Again, it's many times diet related. Deposits of sodium urate crystals can form, and they can get these things called tophi. These are big knots that are in their hand and they don't go away. And then they have an increased risk for kidney stones. So it kind of like all goes in the same category together for these patients. These are the tophi lumps, that's what they're called, that the gout patient develops over time. They don't just show up overnight. They usually are crystals that form there that don't move. And they have them the rest of their life. It's not as common, but I have seen that. So here's our treatment. This is important. This is what we want to do to try to treat this patient with gout. Keep their uric acid level less than 7. So when it's greater than 7, that's how we know that the uric acid is building up in their body and forming those crystals. And the crystals are what creates the pain. It kind of goes into the joint and creates the pain, the joint to become inflamed. They end up with an elevated sed rate because they have inflammation. But the key lab with gout is the uric acid. We want it to be less than 7. The way I always remember that is I want my hemoglobin A1C to be less than 7. I want my uric acid level to be less than 7. When it's above 7, I'm pretty sure that you're having a gout attack. That's what the doctors are usually looking at. When they're having that acute attack, keep them in bed. This is not the patient that's going to tolerate standing up on that foot, because it's only going to make the inflammation and pain worse. And that's only for a short period of time. You treat them with the colchicine, the pain will go away, sometimes overnight. This is a patient, you might pick the bed cradle. That's the thing that goes at the bottom of the bed that you keep the sheet up off of their feet, because they don't even, the pain is so bad, they don't even want a sheet or a blanket on their foot. That's how much that even affects the pain. Limit food high in purines. Again, avoid alcohol. So this is our treatment for the patient with gout. Get their uric acid level under 7. Give them more IV fluids or fluids by mouth. Tell them to keep drinking all the time. Not to eat those foods in the diet that they know triggered the attack. Go back over the last 2 days and tell me what you had in your diet. And many times it's one of those things that created the attack to happen. Don't drink. So you can't drink alcohol. Limit food high in purine. Maintain bed rest when the attack is acute. When the med is acute, when the attack is acute, give them colchicine. When you want to just maintain it to keep them from getting the attack, give them allopurinol. So we have to remember which med goes when. And then this is just a couple questions about arthritis. All right, let's take a break and then we'll come back on here in about 15, 20 minutes. Okay. Any questions?